We now have established very clear guidelines that say we have to know certain molecular characteristics of a patient's tumor before you treat them. Okay, that's standard. It's in the standard guidelines. Whether you do 1, 2, 3, 4 tests in your own lab by your own pathologist, or you send out a much broader test is a personal decision. What has happened over the last decade, though, is that we now have both FDA approval as well as insurance approval, if you will, to do broader testing. And the benefit of doing the broader testing is you're finding rarer mutations, like the MSI, like INTREC, like some of these others that you wouldn't normally look for in a routine, say, colon cancer. But if you do the broader testing, you find the needles in the haystack that can really transform a patient's care. This new technology, the ctDNA technology, has come forward. You can actually order the test. There's an explosion of data to support using this kind of technology. So we have to get up to speed very quickly on what this test can and cannot do. What we want is after a patient has had a surgery for their cancer, for their colon cancer, what I want is a test that simply tells me the patient is cured by the surgery and therefore does not need chemotherapy, or the patient is not cured, there's still cancer around, and chemotherapy will fix that, or better still, you're not cured and the chemo that I normally would give won't do it, so that patient needs the clinical trial. So I think of it as sort of a Harry Potter magic sorting hat where we can distinguish a patient into those three categories. What are we doing now? Well, we're treating all of those patients with chemotherapy, only knowing that we're helping this small subgroup. So this is an incredibly valuable test. If I could go after a patient has had surgery and say, there's no evidence of cancer in you now, maybe I don't give chemotherapy, or maybe I give less chemotherapy. I don't put patients through 3 to 6 months of the burden of chemotherapy. On the other hand, if there still is circulating tumor DNA after surgery, then I know almost 100% that that patient's cancer is coming back. So I have no hesitation about giving that patient chemotherapy. And further still, I can monitor whether the DNA then goes away, right? Did the chemotherapy do its job? And it went away. And so then we know, as best we can today, that that patient has benefited from that chemotherapy, maybe even being cured. The problem is the other side of this formula, is if the patient's blood test is negative. That's a very good sign, don't get me wrong. It really does suggest that they probably don't have cancer still. But the reality is there's a small percentage that have a negative blood test whose cancer still comes back. The test was wrong. It missed it, okay? And so where we're nervous as oncologists is we don't want to miss anybody that we might be able to cure with the chemotherapy. And so where the test falls short today is when it's negative. Because am I sure I don't need to give you chemotherapy? Could I give you less chemotherapy? This sort of thing. I'm not 100% sure. Where it's very useful is when it's positive. I know you're in trouble. I know we should give you chemotherapy, and I can track your outcome. So you can order it today. You can get the result back, but it's critical that we understand the subtlety of this test so we can make the best decision with our patients.